Thank you to the listening audience for joining us today. As mentioned, I'm Dr. Rod Jenkins, Director of the Durham County Department of Public Health. I'm proud to welcome you to this very important webinar on how to protect you and your loved ones from measles. Your presence and partnerships are vital to reinforce our commitment to protecting Durham County from the threat of measles. As mentioned, I'm here to tell you what we've done. And here in Durham, I can honestly say we are prepared. And we are prepared because we've employed a preparedness strategy. The first thing we've done is really focus on early detection and surveillance. We've enhanced our infectious disease surveillance to rapidly identify any potential measles cases. Our work also involves coordination with the North Carolina Division of Public Health in using their statewide measles exposure tracking resources. The second thing we've done is focus on vaccine outreach and accessibility. We've launched targeted outreach to ensure vaccine coverage, especially MMR, for unvaccinated individuals and those uncertain of their immunity status. Clinics are also offering MMR vaccinations and titers to improve accessibility. I'd like to mention that we are open during normal hours and once a month for extended hours in our immunization clinic. The third thing, of course, public communication and education. We've disseminated clear communication through our website and social media to include advising the public to verify their immunization status, to obtain titers if possible, before potential exposures occur. We're sharing instructions on monitoring symptoms for 21 days, contacting healthcare providers before visiting to minimize spread, should the case happen. The last thing that we've done, second to last thing we've done is coordinating with our healthcare system. Our team is coordinating with local providers to ensure mandatory reporting of suspected measles cases within 24 hours. We've reinforced infection control protocols such as pre-visit screening calls and use of negative pressure in isolation rooms when patients are present for symptoms. And we've coordinated with our Office of Emergency Services to ensure that our first responders have the tools that they need to protect themselves and to continue to save lives. Community engagement. We've collaborated with Durham Public Schools, childcare centers, congregate settings, and community organizations to promote immunization and awareness. So what can you do to the listening audience? We have a panel of experts to inform you on all things measles and ways to protect yourself through vaccination. My number one priority to date has been our children. You will hear more about how schools have prepared for this emerging threat. So I guess my final thought is my agency remains steadfast in safeguarding the public's health through vigilant surveillance, prompt vaccination, transparent communication, and strong partnerships. We were well prepared to prevent any response to measles cases. We will continue refining our strategies alongside state and federal authorities. I ask that we move forward with confidence and unity. I thank you again for being here and for your ongoing dedication to this effort. Together, we can do this, Durham. We'll now pass the mic to Dr. Jeff Jenks, our medical director, who will provide an overview of what measles really is.
Thank you so much. And I'm going to start sharing my screen. We have some slides here for you all today. And thank you so much, like Rod said, for your leadership, and those of you who are familiar with our health director here recognize that we can do this, Durham, from I don't know how many years of update videos. So glad to hear you say it live here. It's very exciting for our guests today. All right, are you all able to see my screen here?
You can see it.
Go to presentation mode.
All right, you're able to see in presentation mode?
Not yet.
Not just yet.
Just a second. How about now?
Perfect, Alicia.
Perfect. All righty. Dr. Jenks, you can take it away.
Okay, thanks, Dr. Jenkins. Again, good afternoon, everyone. Thanks for being here. So I'm going to talk a little bit about the measles virus, and Dr. Wolfe is going to talk more about, what we can do to protect ourselves from measles. So what is the measles virus? It's a virus like the flu virus and the COVID-19 virus. It is thought to be the most contagious pathogen to infect humans in the world. So you can see here, I don't know, some of you may remember the term R0 from early COVID, but R0 is basically an estimation of how many people someone infected with the disease will infect. And so you can see here on the figure, someone infected with the flu will on average infect 1 to 4 people, other people with the flu. Someone infected with the COVID-19 virus will on average infect someone, 2 to 5 other people with the COVID-19 virus. And obviously there are factors that play into that. Has someone had COVID before? Are they up to date on their immunizations? But this is just kind of averaging things out. You can see here on the far right of this figure, measles is way over there on the far right. So on average, someone with measles will infect 2 to 18 other people that are not protected against the measles. In other words, if you're not protected against the measles, either through getting the measles previously or through vaccination, there's a 9 out of 10 chance or a 90% chance you will get the measles if you're exposed to someone that has the measles and is transmitting the virus. So what sorts of symptoms or signs should you look out for, if you're concerned that a loved one, for instance, has the measles? So the incubation period is the time between when someone is exposed to a virus, for instance, and when they start getting symptoms. So on average, the incubation period for measles, while it can run between 7 to 21 days, on average is about 10 to 12 days, so about a week and a half. So about a week and a half after exposure, if you're not protected against the measles, you'll typically develop a fever, oftentimes a high fever. Malaise is a scientific word for not feeling well, cough, runny nose, and then inflammation of the white of the eye or conjunctivitis. So that cough, runny nose, another term for that is coryza, and conjunctivitis are oftentimes known as the 3 C's, a way that we can kind of remember what common symptoms are of the measles. You can also get these things called Koplik spots. So you could see here in these pictures, the upper left picture is a picture of what measles rash may look like, and there are some other pictures on the subsequent slides. The conjunctivitis or inflammation of the eye on that top right picture, and then Koplik spots on that bottom picture. They're really these white dots, almost like grains of sand that are on the inside lining of the cheek. And so you'll see these white dots kind of with a red background. If you see those Koplik spots, that is very concerning for measles. Not everyone that gets measles will have Koplik spots, but if someone has Koplik spots, that's very, very concerning for measles. And then about 3 to 5 days after these symptoms occur, people with measles will typically get a rash. You can see here a picture of this rash. So it typically looks like this red, splotchy, flat to slightly raised rash that characteristically starts at the head and moves its way down the body towards the feet. There's not a lot of rashes that do that. So if you or someone, a loved one, for instance, has a rash that starts at the head and moves down towards the feet, that is very concerning for measles. Not everyone will get the rash. Most do, but if someone with measles is immunocompromised, for instance, they may not get a rash, or they may get a rash that doesn't appear like in this characteristic way. And the rash typically will occur, again, about 3 to 5 days after those other symptoms that we mentioned. And people are considered contagious 4 days before the rash appears, and then up till 4 days after that rash appears. So someone can be contagious with measles either before symptoms start or when those initial symptoms begin, which can be relatively non-specific for measles, unless again those Koplik spots appear in the mouth. So, sometimes I'll hear, well, people used to get measles, it's just a virus, you'll get over it, and then you'll be immune from getting the measles again. Well, it's a little bit more complicated than that. It's not just a virus, so it can cause quite a few side effects, some very serious. And so about 1 out of every 3 people that gets the measles will have other symptoms than those we just discussed. So about 1 in 10 will get gastrointestinal symptoms, oftentimes characterized by diarrhea. 1 in 12 will get pneumonia, an infection in the lungs, and that is the most common cause of death related to measles and the most common cause of hospitalization. Although uncommon, about 1 in 1,000 will get encephalitis or swelling of the brain, and that can lead to permanent problems for that person that got measles and encephalitis. So about 1 in 4 children will have long-term complications from that can include deafness, blindness, difficulty learning, and about 1 in 7 that get encephalitis will die from the encephalitis. There's also something called acute disseminated encephalitis, which occurs in about 1 in 1,000 people, and that about 1 out of 10, between 1 out of 5 and 1 out of 10 will die from that. And then something that's not uncommon, but pretty scary, at least to me, something called subacute sclerosing panencephalitis. It's a mouthful of a term, but it's something that can occur on average about 7 to 10 years after you get the measles, and it is uniformly fatal. And so someone that is unlucky enough to get this, they'll get the measles about 7 to 10 years later, just out of the blue, they'll start, developing maybe behavioral changes or mood swings or depression. And then that can progress to jerking of the muscles or seizures, and then eventually coma and death. And this occurs typically over about a 1 to 3 year period. So it's a progressive and can be a pretty prolonged process. So it would be really, disastrous, if this happened to, a loved one or someone in our community. Again, all of these things are entirely preventable with getting the vaccine, which we'll talk about more later. So who's at risk from measles? So anyone who's not immunized against the measles, and those that are at risk are more likely to get severe outcomes if they're younger children, so children under the age of 5, adults over the age of 20, typically adults that are older, and then pregnant women or people with weakened immune systems for various reasons. It could be for medical reasons, or they're taking a medication that may suppress their immune system. Again, people that are unvaccinated are at the highest risk of getting measles, and then also at the highest risk of getting hospitalized for measles because their infections tend to be more severe. And that's what I was going to talk about. I'm going to turn this over to Dr. Wolfe, and I believe we will have some time later on for questions if they still exist after we get through these slides in the talk. So Dr. Wolfe, it's all you.
Hey, thanks very much, Dr. Jenks. I'm not sure if I've got, oh, there we go. Well, actually, again, thanks for the invitation to talk. It's curious whenever I listen to someone else's slides and think about how other people put their emphasis on what we want to cover, because actually we're going to talk a little bit about some similar things, and then I'm going to branch into a different space. And I'm just having, oh, there we go. So there's a different slide, but the same fact, and I think this is important to begin with, that we don't know anything more contagious than measles, and I want to emphasize that by some of the conditions that I've got here on this slide are things that we have almost more fear of. Like we appropriately were very concerned by Ebola. COVID gave us great concerns. We see flu as this very transmissible thing in our community every year. And yet measles is right up the top in terms of the capability of one single case causing a large cluster of cases in a community. And although it doesn't quite present on the slide here, this is also important mathematically because it also helps us then think, right, how many people in a particular community do I need to keep protected in order to ensure that even if a case of measles comes into my county, my town, my school, that it's not going to propagate and continue to cause problems. And unfortunately, that's now what we're sort of seeing in the US is that our vaccine rates in general have fallen low enough that we're not able to spontaneously control measles in the way that we might have done 5, 10, 20 years ago. You can look at that maths and actually figure out pretty quickly that it's about yeah, thanks for adjusting the slides. It's just over 95% of people in a particular community need to be protected in order for the sort of ongoing slow bonfire that can happen with COVID to measles to burn itself out. You can move the slides forward now. So I want to start on this one. This is where we were as a country 10 years ago. If you look up to the top left, you can see average vaccination rates per state. And if you look through North Carolina, for example, and South Carolina, we were above that threshold that as a community meant that even if someone traveled, for example, back into North Carolina with measles, that there were so many people around that person who would have been automatically protected and shielded that measles burnt out. It had no potential to continue to propagate. If you move the slide forward now, though, and compare to where we are now, you see the number of green states have fallen pretty dramatically. Some of whom, the dark brown, actually now fall into a range where, more than 10%, so more than double the safe number of people in the community who are unvaccinated now exist. And so this is very variable, obviously, in a county or across states. There are some pockets where we're really well vaccinated and others where we're not. But I include it as a sort of both a trend line to say that we've lost a bit of ground recently, and this is why we're putting these sort of webinars on to remind people of the importance here. But that even as a state that generally does really well in terms of public health, we have to be really careful to say, look, hey, overall, we're just dipping under the rate of what's going to keep us protected here. Can we redouble our efforts? So let's compare that, unfortunately, to colleagues just south of our border, and this is really what runs a risk of washing into North Carolina. I've highlighted the rates here, for example, in Spartanburg County. So that's the light blue county that you can see just to the south of the border there, where unfortunately, consistent with many counties across the country, unfortunately, there wasn't particularly unique features about Spartanburg, but you can see that their percentage of vaccination has really fallen well below the 95% ideal. And so what we're seeing there is we're seeing this ongoing sort of continual transmission cycle where every positive person has contact with people who are not protected. And like Dr. Jenks said earlier, when you're dealing with a virus that's both transmissible readily through the air, but highly probable of making you sick if you get exposed, it just continues to burn. So we'll move forward. So, I get a bunch of questions when I talk to people or, when I turn on my own sort of social media and think about what feed I'm getting through my algorithm. We probably get a bunch of different questions. And I'm not going to maybe be able to cover everyone's question, but I wanted to cover a few because I think there are some important mistaken facts, myths, if you will, that get propagated, particularly in the last 18 months that we need to just address head on. Dr. Jenks sort of already highlighted the first one really well. This memory that we collectively have that measles is mild and therefore it's probably just better to get it and get it over with. And whilst fortunately for many kids, it doesn't result in long-term complications, I think what we forget as a community is we don't see the kids or the adults from 30, 40 years ago who did not do well. It's called survivor bias. We only see the people like our grandparents or our parents or their grandparents who survived measles and came through okay. We don't see or think about the cost of a young child who gets hearing loss. We don't remember that that's because of measles. We don't think about the cost of admitting someone with dehydration and pneumonia to the hospital where they get other complications. We don't see the people who passed away. So this sort of concept that it's just mild, it's just like a mild flu, sadly, is statistically not accurate, but it creates its own sort of bias, especially when the reality is most of us probably don't see measles. Many of us viewing this may never have seen measles, thankfully, but that doesn't mean we let up our vigilance. I see stories that this is because over time the vaccine is weakening, or our immune system is becoming forgetful, or the recipe and the ingredients have changed. And I'm here just to say that is not true. Measles has been, as a vaccine, contained with MMR, so it's measles, mumps, and rubella, a very stable vaccine now for a couple of generations. There's nothing different about the recipe. What we see, though, is that as our community rate of protection starts dipping, you see more cases pop up. And so the natural sort of tendency to go, well, hang on, like, why is this occurring? Is this a fault of the vaccine? But statistically, it is not. It remains an incredibly protective vaccine. There are, truthfully, 3% of people, we've always known this, approximately 3, who don't gain a meaningful protection from the vaccine or can still get sick afterwards. And this is a group of people who probably have either some underlying immunosuppression that leaves them prone to getting measles anyway, or there is always a very small proportion of people who just don't respond in the expected way to the vaccine and gain the right protection. But again, even if you were traditionally in one of those 3% of people who didn't get a perfect response, you would be protected because everyone else around you was safe and you weren't going to get exposed as a result. That sort of community protection around you is what has fallen down in the last couple of years in the US. And so actually we want people to be aware of their status. The biggest thing that probably almost sparked a little bit of the anti-vax movement in general was a paper now more than 20 years old that sort of suggested, with a very small number of British cohorts, that vaccine for measles could trigger autism. And in fact, this actually really led to a very close investigation of that event. And not only was the original paper found to be inaccurate and has since been retracted, with all but one of the authors saying, "Look, hey, this is wrong data." But it's led lots of public health teams to go back in their respective countries and think about the way that they're, many millions of people who've been vaccinated against measles, and look at what's happened with autism. And that's been disproven. I've got a couple of slides on it later on. It doesn't take away from the fact that autism has increased in our community. It doesn't take away from the fact that we've really struggled to understand autism in a way to best help manage that, to best help protect against that. But just because we don't understand what autism is, does not mean that we haven't beautifully dissected out the fact that the MMR vaccine actually has nothing to do with it. And so whenever you hear a discussion about MMR and autism, in fact, it's a disservice, in my mind, to people who really are trying to figure out autism carefully, and families who are going through with kids and family members who have that condition. Because we do need to do more autism research, but we also need to recognize when things are put aside because we've proven that that's not associated. The final thing I sometimes hear is like, my kid gets a lot of vaccines. Like, do we really need to give him measles, mumps, and rubella if all we're worried about at the moment is measles? And it's a good question, because I want to address it a few ways. The first is, when we actually went through the research to come up with the current vaccine, originally we had a measles vaccine, we had a mumps vaccine, we had a rubella vaccine, and we were able to show that each of the three were very effective at prevention. We were then able to safely show that actually, if you combine all three together, you don't lose the strength of each individual ingredient. And part of that comes down to the fact that, on a daily basis, our immune system gets stimulated by thousands of viruses every day, bacteria, fungal problems. So our immune system is actually really designed and built to be very capable of handling multiple challenges. It's not to say that it's not tough to, physically find a place to get down to the local health department or clinic to get the vaccines. There's logistics involved. But the idea and the mistake to think that we overstimulate our kids boy, I just need to look at my 10 and 12-year-old and think about how many handfuls of dirt they took as a kid to realize that the amount of exposure to lots of things that we train our immune system to is actually really quite natural. And that hasn't proven to be a problem. In fact, if people are nervous about the way that vaccination sort of can natural infection somehow do a better job at helping train your immune system, I'd like to remind people that we also know one fact about measles that really troubles me. Not only can it linger in the body for a long time, as Dr. Jenks said, it actually almost performs a bit of a reset to your immune system. So you actually, recovering from a measles infection, forget immunologically about lots of the defenses that you may have previously laid down. So it actually almost takes away um, protection that you might have had if you get infected, which the vaccine just doesn't do. You can slide that slide forward, actually. Thanks. Um, there's a lot of talk about who should get reprotected. And whilst there's different age spectrums here, those of us who are getting a few more grays in their beard and maybe born before 1957, we were probably so likely to have had measles back then when the rates were sort of much more universal that we're likely protected. There's these middle year brackets that I have here where I would leave people the challenge and the encouragement to say, speak to your provider, speak to your doctor about whether or not you have records of your vaccinations. Talk to them about whether there's utility on getting some serology testing to say, look, hey, do I have proof here? We do that very carefully for a lot of our patients who we know, for example, are about to go under immune suppression. Prove to me we've got protection for this person. And actually, you can't really run into any problems even if you took an extra vaccine that's proven very safe. So let's click on this one more time. I want to talk about a different use of the vaccine, though, that equally sort of hits home to me why this is so important. Let's say you're someone who hasn't had, for whatever reason, a vaccine, or you have a child in the house who haven't got around to vaccinating yet, and you then find out that you've been exposed. There is actually a very short window of time when a post-exposure vaccination can actually offer a brilliant degree of protection. And we'll click forward one more, please. There's some issues on that slide. There's actually been other outbreaks in the United States before where we've had the chance to look and see, a big one in New York about a decade ago, where hundreds of kids, unfortunately, were exposed. And when we were able to go back and quickly find out who wasn't vaccinated and yet who's been exposed to measles, offer vaccine to those who were exposed, about 85 to 90%, depending on which study you read, of those kids will not prove to get measles. I'll remind you of Dr. Jenks' statistic at the beginning that an unvaccinated exposed person, 9 out of 10 will get sick. Here's an intervention where you can stop sort of 5 out of 6 of those people getting sick, which is pretty remarkable, actually. But the timeline here, you've got 3 days to do it. So when you hear people in public health talk about the urgency of hearing and finding and calling people about measles risk, this is why, because we have a small window of opportunity to get in and do something. We'll move forward again. To be fair to the whole community, there's a very small proportion of people who should not get vaccinated. And these people, if you think about it, they rely on the rest of us giving them a ring of protection. These are generally people who don't have an immune system that's either developed enough yet or capable enough yet to protect themselves. So it's very young kids. So we typically give our first measles dose around the age of 1. There is good data that in the midst of an outbreak, you can probably push that down to sort of 6 to 12 months. I'd encourage parents of really young infants that they can talk to their pediatrician about that. But kind of less than 6 months, we don't use the vaccine. Pregnancy is its own sort of immune storm, if you will, and so we don't give a living vaccine at that stage. And then there's people who actually take immunosuppression. We use the word immunosuppression, but it's actually a very broad bunch of people, from some people who are heavily immunosuppressed, they've had chemotherapy, to people who might take a little bit of prednisone periodically. And I'd really encourage people to talk to their prescribing provider to say, How much immunosuppression do I have? And is it enough that I can't consider a measles vaccine? It's quite variable. Generally speaking, chemotherapy transplant means you probably can't. Generally speaking, a little bit of anti-inflammatories, often you actually can do it really safely. But that's a one-on-one conversation. People do learn differently. I'm going to maybe end with this slide if you don't mind. I'm a visual learner. That helped me through med school sort of remember things. And so honestly, this comparison chart was put out by an ID colleague of ours a good number of years ago, and to me it just sort of clicks in. It's like I can talk about the risks of a vaccine, but what does it actually mean in comparison to just not getting it? And so what's here on the left is a graphical display of, if I look at that whole box, I'm talking about 10,000 kids, let's say they get measles. What's their risk? The size of the box is the size of the problem. So like we talked about earlier, 2,000 hospitalized, 1,000 with the risk of hearing issues and potential hearing permanent loss, 10 kids who are going to die, 10 to 30 kids. Let's come over to the right side of the box. And if I vaccinate 10,000 people, what happens to them? Now, there's no intervention that I can give you, from a Tylenol to an MMR vaccine to chemo, that's going to be perfect. But this is pretty darn good. So you see those tiny boxes by comparison, where less than 1% of people have any sort of problem with these vaccines. There are, for example, a few people who get an allergy to a vaccine, but 0.035 out of 10,000 is a blisteringly small number compared to those issues that we see with measles. So, some people find this just better to see it. And for me, this was always important to go, yeah, I've got to kind of reset my assessment of risk here. This is worth me pushing and doing aggressively. And of course, I've vaccinated my own kids to emphasize that point. So I'll actually pause there. I know we might have questions towards the end. I'm happy to keep answering them as they come, but you can skip through the last few slides.
Thank you so much. Yes, we definitely have questions, and we will get back to them at the end. Before then, we're going to let our school nurse program manager, Sarah Snyder, give a brief overview of what's going on in schools, because I know lots of parents have sent us questions. So we want to give her a few minutes to speak, and then we will get back to questions.
Thank you, and excited to have everybody here this evening. My passion is keeping children in our community safe in schools, and measles is part of that. So we want to talk a little bit about preparing your schools for measles and how we keep children safe, being proactive. So we're going to get into our slides. So we are grateful enough to have many partners to collaborate in this preparation for measles that we hope that we don't need. And that includes all of Durham County schools. So I've been lucky enough to work with charter schools, private schools, and our public schools here in Durham County, who have been all extremely receptive and very interested in the measures that they can take at school to prepare and keep kids safe if this were to come into their schools. And so what does that look like? We have provided a number of educational materials to all of these school settings. We've given guidance on how to manage exposures. We've provided access to our North Carolina immunization registry. And for those of you who may not be familiar with that, many providers in our community and across the states use the registry to input immunizations that are given to children in our community. What that provides us is a central, essentially warehouse of data where we can access records for children who are in schools fairly quickly. We have also provided direct access to all of our schools in the county for public health, available at any time. And this is something that's available really at any time for many reasons. But for measles especially, we want to make sure that they are aware of their resources. We have and are planning school-located immunization clinics at very select sites. And I think that a common question might be, how are those sites determined? Can that come to my school? We use a variety of factors to determine those school sites, and as Dr. Jenks spoke of before, that 95% threshold of vaccination coverage is really our goal. And so when we get into a conversation with a school who might not be quite there, that is part of the conversation, although it is not the entire conversation. And lastly, although I am here tonight, we collaborate across multiple areas within public health. So I work very closely with Dr. Jenks, Dr. Jenkins, and our communicable disease clinic, and many other areas within public health to bring these resources to our schools. So how does that translate into what your schools might be doing right now for those of you with children in any of those school settings? We are encouraging all schools to review records for students that might be missing proof of immunization. And this is focused on that measles, mumps, and rubella vaccine, the MMR, right now, but we know that other vaccines may be needed. And so my team is incredibly passionate about making sure children have what they need. And we have tried to have conversations that involve not just MMR, but other vaccines that might be needed and provide resources for families who need that. Part of this is reviewing that immunization registry I spoke of, but we are also requesting immunization records for students. And if you are a parent listening, you're not sure if your school has immunization records for your child, we recommend just going ahead and sending records in as soon as possible. It is absolutely going to help your school in the event it was ever needed, and it will ensure that they have what is required for school. Of course, there are many staff in the school building we want to keep safe as well. So we're encouraging staff to have access to their own immunization records. As Doctors Wolfe and Jenks spoke about, sometimes it's immunity from infection, sometimes there's vaccination. And so as we age, we often lose track of some of those records that were created when we were young. And so this is a good stopping point to encourage staff to have access. We've talked about measles. We've talked about how it spreads. In case of an exposure at school, staff and students are generally asked to stay home from school for 21 days if they are not properly protected by the MMR vaccine, or if they have a medical or religious exemption in place and they do not have those MMR vaccination protections. There are some options, as was also mentioned, for post-exposure prophylaxis or vaccination if it's within the proper time frame. However, our goal is really to ensure that everyone in the school building is aware and has the opportunity to discuss vaccination with their provider so that we can keep kids and staff in school with us. Next slide, please. So for school buildings specifically, we are working with all of those schools I spoke of earlier to have a plan. If measles were to come into their school, we've given them specific direction on what they may need to do very quickly. And that includes, in part, identifying a space to isolate suspected cases until they can be taken home by a parent or guardian, and maintaining specific supplies to protect people and make sure we have clean spaces at school. Next slide. So we talked a lot about vaccine. But we realize that not everybody has ready access to vaccination or a provider. And so we want to be sure that you and our community know that you do have options. So typically we recommend, if you do have a pediatrician or a primary care provider that you seek care from, please have a conversation with them about vaccination. Ask them to look at your child's record and ensure that they're completely up to date, not just for MMR. If you have a school nurse, they can provide resources. We also have a resource here at the health department. Our immunization clinic is readily available to give MMR or any other vaccines that might be needed for you or your family, and their numbers are here on the screen for you to contact as well. Okay, so many of the questions that we get are about what actually happens if measles comes into my school. And I did want to talk a little bit about what confirmed actually means in a school. And so confirmed is essentially a clear diagnosis of measles in a person. And in the school setting, what that means is that we have confirmation from a healthcare provider or the health department that that person has been diagnosed with measles. When that happens, whether it's a charter school, private school, public school, daycare, other settings in our community, they are typically working very closely with our health department communicable disease clinic. And so I want to provide a little bit of reassurance that all of the guidance that these agencies receive is from public health. They will walk through who may have been exposed to a person that's positive for measles, what exposure might look like, and designate who we need to understand vaccination status and who might need to be excluded from a school setting for the safety of all people there. And so in a school setting, briefly, what that looks like is if a child or a staff member is at school and has confirmed measles, the airspace that they are in that may have exposed people is included in that exposure. And so, both doctors spoke to how easily measles can expose other people. And so this really affirms our goal of getting vaccination and protection for our students and staff in place. How will you know if your student is exposed? That guidance from public health includes notifying parents and guardians of children who might have been exposed at school or who have definitely been exposed at school. So typically that is for every communicable disease that needs to be reported to the state, not just measles. And so some parents in our community may have had that experience, but we do provide notification and resources for any questions that you might have if that were to occur. And lastly, I know we're right in front of you right now. We encourage any questions that you have. But after this, if you have more questions, there is a Durham County Department of Public Health measles hotline. The number is here on the screen. Our social media has been very active with more information than you could want right now. So please just know that we are at your disposal for support.
Thank you so much, Sarah, and all of our presenters here. We do have questions. We gave people the option to submit questions in advance, and if we had time for additional questions at the end, then we would do that also. But we've received enough questions that we are not going to have time for things that were not submitted in advance, which is great news. We're glad people are participating. So a lot of it was addressed in the presentation. So I'm going to try to do the ones that were either, excuse me, asked a bunch or were not addressed. So first question, either of the doctors here could answer. One that we get a lot. I've heard about lots of folks' immunity wearing off. I was vaccinated decades ago. Do I need to have my immunity checked?
I'm happy to tackle that. As Dr. Wolfe mentioned, these vaccines, especially if you get two vaccines, the protection is around 97%, and that is for life. It can get tricky if you get a titer, so an antibody titer. The immune system's like an orchestra, and when you're checking an antibody, that's almost like just asking a section of that orchestra to play. So it could be that you got both doses of the vaccine, and then you go get an antibody titer, and that titer is undetectable. So it may be that those antibody kind of memory cells have fallen below the detectable limit, but there may be other parts of your immune system that are working and would protect you against measles if you're exposed. And so the general recommendation is, in most cases, if you've gotten 2 doses of the MMR vaccine, you don't need to go get a titer to check your immunity. It's presumed that you're immune. And again, like Dr. Wolfe mentioned, nothing's perfect. So the average immunity is 97% with 2 vaccines. But I generally don't think getting a titer is worth it if you've gotten both measles vaccines.
Yeah, I'd lean into that and agree. And actually, a colleague of mine in our vaccine institute here highlighted a recent study that looked at a big cohort of people who were tracked over time and then sort of modeled the loss of cells that would allow for good vaccine protection and extended that to go, right, how long this protection is going to last. And actually, if you draw it out theoretically, those cells last for hundreds to thousands of years, not simply a whole lifetime. So in actual fact, that it's quite protective and likely to be for our entire lifetime. Really the only groups of people who I get nervous about are those who I've introduced something that will mess up with your immune system. So if I've introduced chemotherapy, if I've given you some form of immunosuppression. Maybe you're someone who's acquired HIV, for example. Like there's something that's tinkered with that immunity, but generally it's absolutely lifetime protection.
Thank you. And it's different but similar by way of, I'm not sure if I'm immune still. Someone asked, if I can't find record of vaccination, is it safe to go ahead and get vaccinated again?
Yeah. We do that a lot for healthcare workers, for example, where it's, most important for them in front of sick people to be themselves protected. And there's no problems about doing that. We know the standard recommendations give you essentially lifelong protection, but there's nothing that means that if we're not sure that you can't do it again, there's no complications of additional ones. So that's quite safe.
Dr. Jenks, you agree that's pretty simple, straightforward answer?
Yeah, I agree with Dr. Wolfe.
Another one we get a lot because, and Dr. Wolfe, I loved your chart where you could visualize the pros and cons of vaccination, but we get this question a lot. Could you speak to the risk of encephalitis from the measles vaccine?
Yeah. So we don't tend to think of encephalitis from the vaccine as such, but we can, there is a risk of what's called febrile seizures, which sometimes gets confused with encephalitis. So encephalitis really refers that there's a sort of an active inflammation within the brain, in the case of measles from the virus. I think any cause of infection or vaccination or sometimes medications can lead to a very small group of youngest kids. And so typically this is in children who are sort of in that 1 to 2, 2 to 4 sort of young age bracket, um, to sometimes get a fever. Actually, most adults probably recognize that we sometimes get a low fever when we get vaccinated or run into an infection. That's part of our immune system's response to getting stimulated. I think the statistic that came up on that graph was that about 3 in 10,000, if I quote my own statistic correctly, I'll double check. Young kids will get what's called a fever seizure, in a febrile seizure in the aftermath of a vaccine. And that's not just unique to measles, that's actually common across many vaccinations. And look, as a parent, that's pretty scary. Don't get me wrong. That's affronting to a parent to see your kid go through that. But there's no real evidence to say that that is a lingering problem. It's a reaction that a young developing brain has to the injection of the vaccine, but it's not something that lingers. It doesn't affect that kid's protection in the long run, which is still excellent. And it's something that pediatricians are very familiar with managing. So there's not really an encephalitis due to the vaccine per se, although there is that low risk along with any vaccination of seizures. I like that graph because it doesn't shy away from the fact that that risk exists. It exists with many interventions that we have that we know work, but it puts it in comparison to the reality that, the actual risk of encephalitis due to measles is orders of magnitude higher. And I think 20 years ago, if parents made a decision to go, we haven't seen a case of measles in North Carolina in umpteen years, I don't want to take that risk for my kid. Proportionally, that was an argument that people could have. I want to re-emphasize to people that we have lost our current US ability to control measles. So your ability to rely on everyone else in your community of simply protecting your kid from that complication, to me, is gone. We can't sit here and say that that no longer exists. It used to be that only if I was going to travel to somewhere internationally that I'd run a risk. That is done. And so put those risks beside each other on a table and say, here's the risk of a problem with a vaccine. Here's the risk of the very real problem if I get measles, which I'm likely to, unfortunately, now in my lifetime be exposed to. Sorry, went on a bit there.
No, thank you. It's a good time to ask this question also that
I
we
would just
received.
add,
I'm sorry, Dr.
Alicia,
Jenks.
yeah, real quick, about 2 to 5% of kids get a febrile seizure at some point in childhood. So just to reiterate, I think you're much more likely to get a febrile seizure, with measles. We talked about measles can cause a high fever than getting a febrile seizure from the vaccine. I just wanted to kind of emphasize that too.
Yeah.
Thank you. Sorry to cut you off. I was looking
No,
at
you're
my
good.
question list here. But speaking of Dr. Wolf's point that you're likely to be exposed to measles at some point in your life now, we got this question also. Does any recent data or literature support or suspect that this could become a pandemic?
No, I don't think so. I mean, so when we think of let's think of the definitions of pandemic to begin with, and that, that sort of defines a multi-country, multi-continent outbreak that was sort of typically we think of it as being unexpected and rather sudden. So I guess on some level, we can say that, yeah, look, the United States is not the only country going through measles resurgence. Like we're not the only one who have vaccine problems. So this is a multi-continent problem. But, let's compare it to COVID. So that whole first year of 2020, we didn't really understand what was happening to COVID. We hadn't seen it before. No one was vaccinated. No one was protected. We didn't have a vaccine. We didn't have any understanding of whether those vaccines would be as wildly successful as they ultimately proved to be. None of those problems exist here. We have a vaccine. We've had many hundreds of millions of people go through that vaccine. We understand how it works. We understand how measles has worked. This hasn't mutated. Measles doesn't, unlike sort of typical pandemic viruses like flu or coronavirus, actually doesn't mutate to the same sort of degree where we'd expect some sort of sudden change to make us all at risk again. That doesn't happen here. So I don't really see it as a pandemic potential virus, but I think we've got to reset the way we think about it, which is like previously I didn't really have to think about measles too much based within the US, whereas now I now do.
Yeah, I agree. And I think, we are at risk. So, from a public health standpoint, measles has been eradicated in the United States since 2000, but we're at risk of losing that status. So I think I agree with Dr. Wolfe. I don't think it likely is going to reach pandemic potential because so many people are immune from it, but it's likely at this point that it's going to be endemic in the United States, which means that it's going to be an ongoing problem that we're going to have to deal with, going forward, just because vaccination rates are declining, and that's scary in itself too. The thought that when I went through medical school, if you would have told me in 2026 that measles would be at risk of becoming endemic in the United States, I would have laughed. It would have just seemed ridiculous, but that's where we're at.
Thank you. We'll do one for Dr. Jenkins here, and then if we have time, we'll get back to you two doctors. Someone has asked, will the health department host vaccination clinics like for COVID?
If necessary. We have, again, employed the strategy of going to those areas in which we feel like vaccination rates are low, particularly with during public schools. But should the need come for us to really stand up additional clinics, we will. But as my opening message said, we do have extended hours once a month, and we encourage the listening audience to take advantage of that, to include our regular hours in which we are more than welcome to welcome the public to check their status and get immunized if they need to.
Awesome. Sarah,
If I,
hopefully you don't
if
feel
I
left
can
out.
just
Yeah, go ahead.
If I can just add a tiny bit to that, I mean, I think not only would, wearing my DUCAT, we've participated in vaccine clinics as needed before too, and would certainly chip in if the rate suddenly jumped in our area. But I would see the last couple of months as a big opportunity. We sort of had a real scare when we've had local people in the county who've been positive, and knock on wood, they have not caused outbreaks for us here yet. Clearly, that's not the case in our dear neighbors just in South Carolina. So we have a small window of opportunity, but it's not today. The sort of the idea of some of the clinics that we set up in COVID, this isn't that pressing, but it's here, and we have this little window of opportunity that, in fact, recent cases have given us to go back over your vaccination status, have a look at your schools, have a look at your employee base, and sort of say, hey, what's the rates here? So um, it's a it's a real sort of fortunate window in some ways.
Well said, Dr. Wolfe. And being a South Carolina native and really seeing what's going on in the upstate, being I'm from the low country, but really seeing what's going on upstate, I would hearken the words of Dr. Wolfe, and to the listening audience hearing my voice, I would just say, don't wait. Please don't wait. We have this window, take advantage of it.
Thank you. Maybe one or two more, and then we'll say our goodbyes and do some parting thoughts. But seen the feedback that, oh my God, cough, runny nose, fever, there are so many things that could be. And so someone specifically asked, are there any telltale signs that help identify measles versus other viruses before rash appears? That one's a pretty good sign, but before you get to that point, probably.
Yeah, I think it's a good question and it's a good point. Those initial symptoms are pretty non-specific. I think them together should tee you off, especially if it's a person that's not immune to measles. And then those Koplik spots that I mentioned, that would be more of a telltale sign. The rash really is the most telltale sign, but again, that generally occurs for 3 or 4 days after those initial symptoms appear. So I think that really underscores to me, yeah, a lot of the symptoms of early measles are nonspecific, and that just underscores the importance of getting vaccinated and being immune. And so that's one less thing that your kid gets sick and that you have to worry about. I mean, it should still be on your radar. I think, especially in the current times, just because the measles vaccines aren't 100% protective, but I've vaccinated my kids like Dr. Wolfe has, and when they get those sorts of upper respiratory symptoms, I think other things besides measles because I know they're largely protected.
I think it's also important to recognize when your infectivity begins in relation to the rash. And the frustrating part here is that the moment your symptoms begin, even in that really non-specific phase, you are highly contagious to all those people around you. And by the time the penny often drops, which is when the rash appears, because that's the most characteristic thing, as Dr. Jenks said, you've been contagious for 4 days. So if that person's turned up with their flu-like illness into the ER, for example, or a clinic, um, it's really hard to pick that they might have measles. And you are spot on the money to say, like, actually the biggest determining symptom, if you will, is this person a vaccinated person or not? We used to previously be able to say, are you vaccinated and have you traveled outside of the United States? Whereas unfortunately, that differentiating factor nowadays is probably not there. I mean, I still think it's useful to say, are you not vaccinated and have you recently come back from upstate South Carolina? Like, that's got my attention. But it's clinically very hard to tell. And honestly, if you're waiting for the rash to appear, you've missed a 4-day boat.
Thank you. So we are technically out of time here, so I'm going to wrap us up. First, thank you all to our panelists. This has been helpful. I read and talk about measles all day, every day, and I feel like even I've learned something here today. We didn't get to all of our questions because we got a lot of fantastic questions, but Dr. Wolfe has generously offered to help us answer some more after the fact, and I'm sure our team will as well. So I'll try to get some stuff written up and posted on our site and our social media, and we have a measles page at decodepublichealth.org/measles. And for those of you who follow us on Facebook, you already know we talk about measles more than anyone wants to hear. So I will try to follow up with all of that in the next week so you can check that out on our page. Thank you to everyone who participated as well. Sorry we could not get to so many questions, but want to give our panelists a chance for any closing thoughts before we wrap up for the day.
Alicia, if it's okay, I'll just go. I'd just like to thank Dr. Jenks, Dr. Wolfe, our international subject matter expert who's coming to us live from Australia. Thank you for taking the time to be with us to really serve the community that you work in and that you so love. But as we said probably a few moments ago, now is the time to act. We have a very short window. We certainly don't want to be caught flat-footed. So to the listening audience, I would just say, please, please listen to all that was said, take action, and please make sure that you do all that you can to protect yourself and your loved ones.
Thank you, Rod. Dr. Jenkins. Anyone else?
Yeah, I echo that. Yeah.
So much to
Yeah,
everybody
same.
who came to help keep our community safe.
And I just appreciate some good collaboration here. This is a lot of people working really hard in the background to try and keep us all safe. That's just wonderful.
Thank you so much. And again, thanks, Dr. Wolfe, coming to us from Australia. It's either very early or very late there. I forget which one. So we really appreciate it.
It's very
And
early tomorrow.
oh, sorry to hear that.
No,
But
that's
thank you
good.
all again. Thanks for those who tuned in and check out our site. I'll try to have some more information posted by end of next week, and I hope you all enjoy your evening or morning if you're in Australia.
Thank
Thanks
you.
all.
Thank you to
Bye.
everyone.